Namaskar and a very warm welcome to this edition of Let's Talk Health, Urology and Renal Queries. I'm Nidhi Kumar and you're watching India Science. Well, India's cumulative COVID-19 vaccination coverage exceeds 178.90 crores and India reported 4,362 new COVID cases. More than 48 lakh vaccine doses have been administered in the last 24 hours and the recovery rate currently stands at 98.68%. As COVID 19 continues to worry us in the country, COVID related queries are on the go. People are speculating about various complications in health. In this program, we take your questions from Facebook and YouTube Live. Today, we are joined by the very eminent Professor Dr. Anup Kumar, HOD Urology, Robotics and Renal Transplant, Safdarjung Hospital and VMMC. Many thanks for joining us today, Dr. Anup.
Good evening, Vijay.
Thank you for joining us on India Science. I'd like to begin by asking you to tell our viewers about the current urological disease scenario in India in view of the new strains, and how do you prioritize urological management in such times, doctor?
So when we divide the urological diseases, we divide into one is infections, kidney infections, number two, kidney cancers, number three, kidney stone, and then there are certain congenital problems which can occur in the kidney, and number five, kidney failure. So these are the five major categories of kidney diseases which we talk about. Now, in the current COVID scenario, which is going on for last 2 years, definitely it is a challenge not only for the patient but also for the doctors at how to deal with these problems. For last 2 years, what we have seen that patients who are coming to our OPD, as we have a huge numbers who attend our OPD daily, they could not come because of the restrictions throughout the country, and so they could not come for the follow-up. Many of the patients, they suffered, starting from the infections, stones, cancers, all category of patients, they suffered. But what we did that even during the last 2 years of COVID, we never stopped our OPD completely. As per the guidelines received from the Ministry of Health and Family Welfare, we continue to operate our OPD daily on daily basis, and also we also started the facility of the e-Sanjeevani on the directions of the ministry. So this has been started recently, and now there is a provision of teleconsultation also for those patients who can log in and they know how to use the internet for the teleconsultation. We have in the last 2 years prioritized the treatment of cancers and kidney failure. So these are our two main priorities because our OTs were also restricted because of the last 2 year COVID pandemic. So we have given the priority to kidney cancer patients, prostate cancer and bladder cancer patient treatment, as well as the kidney failure. Initially, the transplants were stopped because the COVID was really making a havoc across the country and a lot of fatalities were happening. But then gradually the transplants were restarted, and therefore we started giving priority to kidney transplant patients as well as the cancer patients. So these are the last 2 years. Our priority has been to the cancers, kidney failure like transplant patients, and of course the infections, because many patients comes to us with abscesses, collection of pus in the kidney, in the bladder. Those patients, they require immediate admission and intervention in the form of we have to put a tube in the kidney to drain the pus, to put a Foley's a tube inside the bladder to drain the pus, and put them on some antibiotics. So these are the patients we had to give priority. And of course, the stone patient, the kidney stone patient also, they have complications in the form of infection, and these patients also required special attention in this period. So overall, I can say yes, patients and the doctors, they had a challenging time, but now with the grace of God, the third wave has already on the declining trend, and now our all services have reopened in full strength, and we are seeing the patients as we were seeing the pre-COVID era, and we are seeing around 600 to 700 patients per day. Our OTs are also operating full strength, and therefore now patients are coming back for the follow-up after 2 years. And whatever now we can do, we are doing to recover the loss they have suffered. And I think now it's important that patients who could not come for the last 2 years, they should come now for the follow-up. whatever disease they were having, they should come and follow with their specialist doctors because otherwise they can have more complications.
Absolutely, doctor. You mentioned a few urological diseases. I'd like to know from you, what are the symptoms of these diseases? Supposing you have a stone, how do you get to know? What is that you need to watch out for?
Patient has the kidney stone, patient will start having the pain in the abdomen. Number one. Number two, patient can have burning sensation in the urine. Number three, patient can have nausea and vomiting. The feeling of vomiting can be there, or it can be frank vomiting. Number four, patient can have sometimes a small lump here, which he can feel or she can feel because the kidney is enlarged now because of the stone obstruction. Patient can have blood in the urine, which can be because of the trauma of the stone causing eroding into the mucosa. And patient can also have high grade fever because stone patient can have infection because of the obstructive uropathy. And finally, these patients can have kidney failure. If they persist, this stone patient persist with the same kind of pathology, they don't take the treatment, ultimately they will end up in the kidney failure. And that time they will start having the problems of decrease in the urine output, swelling all over the body, and nausea, vomiting, decrease in the appetite, and decrease in the weight loss in the decrease in the appetite. So these are the symptoms, I can say, broad symptoms of kidney stones.
Right, doctor. And what is the management for these kidney stones? Or how
So,
kind
so
of
the important
diagnose and manage, sir?
So the important thing is to diagnose these patients at the right time. As I said, if we ignore this patient or patient ignore themselves, they can have ultimately kidney failure and kidneys are lost forever. So it's very simple to diagnose. They should consult a specialist doctor, urologist in the nearby area. We get a simple ultrasound of the abdomen done along with urine examination and blood investigation. And as per the refining of the ultrasound, we go for CT scan. A CT scan is again a very readily available investigation in all the government hospitals. And after getting the CT scan, you have to plan the treatment according to the different parameters. Number one is the size of the stone and the site of the stone. If the stone is in the kidney and the size is less than 1 centimeter, we can go for ESWL, that is extracorporeal shock lithotripsy, in which no anesthesia is required, no incision is required. We break the stone from a laser coming from outside, and the patient will pass the fragments of stone through the urine. So this is a non-invasive kind of treatment, but in selected patients, as I said, size less than 1 centimeter in the kidney or the ureter. If the size is more than 1 centimeter in the kidney, up to 2 centimeter, we can go for RIRS, which is a retrograde intrauterine surgery. We use a specialized scope. We go through the urethral orifice and we go up in the kidney and we break the stone using laser. So the inside is a corporeal laser. So this is again a very advanced technique, and through this we can remove the stone completely. Patient can be discharged next day. There is no complication overall if it is done by an expert surgeon, and no morbidity. So these are the advanced technology. If stone is less than 2 centimeter. If stone is more than 2 centimeter, then the technique which we are using is PCNL, percutaneous nephrolethotomy, in which we make a small puncture in the back, and through that puncture we use a small scope known as nephroscope, and through that scope we break the stone using various energy source. So this is again a very, very important and advanced technology. No big incisions are required, and we can completely clear the stone. So these are three main modality of stone treatment which we can use. And of course, if the patient come very late and kidneys are already lost, kidneys have become non-functioning, then we have to remove the kidney. That we can do by a laparoscopy.
Yes, doctor. The next question is from YouTube by Deepyanti, and she's asking, how do you prevent kidney stones formation?
Very important that prevention is always better than cure. This is what we always teach our patients. So number one, you have to keep your hydration better. And our recommendation is for adults, 2 to 3 liters of fluids per day should be taken. And in winters, it can be up to 2 liters, but in summer, it can be up to 3 liters. This is how we divide it. Plenty of vitamin C containing fruits like lemon and orange you can take, because it decreases the stone formation. Number 3, you decrease your salt intake, because increased salt also increases the stone formation. Number 4, you decrease the intake of dry fruits, especially the cashew nuts, because they also promote stone formation. Number 5, if you have any underlying kidney problems, you should get them treated at the right time. As I said, some patients have congenital obstruction in the kidney. And if we ignore those problems, they can cause stasis of the urine in the kidney and form stones. So if we treat these patients in time, then stones will not be formed. And then, of course, when certain areas in the country are endemic for stones, like our North India, especially the Rajasthan belt, because it is a tropical kind of climate is there. So there the water contains a lot of minerals which are having very high density. So what we recommend these patients is you should use RO filtered water or boiled water rather than consuming the raw water, because this will also prevent stone formation.
Yes, doctor. My next question is, we see a lot of accidents every day happening here and there, and in case of injury to the kidney, doctor, what kind of trauma is there with the patients, and how do you manage that? What is your advice?
As we know, India has a lot of road traffic accident patients per day, and in fact, it is one of the largest in the world. And Delhi is, of course, one of the largest city in the country, having the largest number of road traffic accidents. Kidney is one of the organs which is mostly affected, along with the spleen and the urinary bladder and the bones. These are the other structures which are involved. When the kidneys are involved in trauma, patient can have pain in the abdomen and can have blood in the urine. And also the distension of abdomen can there because of the collection of blood inside. So there are different grades of renal injury, renal trauma, which we can assess by using a CT scan. So any patient who has got a road traffic accident, he is brought to the emergency department of the hospital. There a team of doctor assesses the patient, and there we do a quick ultrasound, which is known as fast sequence ultrasound, and we look for the injuries which has happened in the abdomen. If we are suspecting a renal injury, patient is stable, we go for a CT scan abdomen with contrast, and through that CT scan, we can grade the injuries into grade 1, grade 2, grade 3, grade 4, grade 5. There are 5 grades of injuries on the kidney. If it is grade 5, the kidney is already gone. That means the kidney has become shattered because of trauma and the blood supply has gone. So this kidney cannot be revived, and ultimately the patient will have a non-functioning kidney. However, in the grade 1 trauma, we have a conservative management. We admit the patient, give him fluids, give him some blood and some antibiotics, and gradually the patient recovers on conservative management. Similarly, grade 2 also, patient can have recovery on the conservative management. But if it is grade 3, that means if there is injury to the urinary tract along with the kidney, sometimes you have to put a stent from below. It's a very minimally invasive technique. We put a stent from below so that there is no extravision of urine. This is grade 3. And grade 4 is when a part of the kidney is injured and there is a hematoma collection around the kidney and it is expanding. So this is a real emergency. This is the only emergency, I will say, where you have to rush. Sometimes you don't have time for even CT scan. Patient comes to us in the emergency, he is collapsing, his BP is falling, pulse is increasing, and when we see the abdomen distension is increasing, this is a patient to be carried to the OT directly, and there we explore the patient. Some of the patient we can do renography, we can repair the injury and salvage the kidney, but most of the patient will end up into removal of the kidney.
Absolutely. Nisha is asking us on YouTube that you have made a new record in Asia in 100 live robotic and 3D live surgeries. Could you please elaborate on this?
Yeah, so this is again a proud moment for whole country, because this was started 4.5 years back, and this was on the directions of the Ministry of Health and Family Welfare, Government of India, because they have online education e-health platform through which 52 medical colleges across the country, they are all connected to each other, and out of those, the VMMC is also, Safdarjung is also one of the part of that. So we started this 4.5 years back, and our aim was to teach and train our young urologist students and young urologists, not only in our country, but also those urologists who are from the other countries. So what we do one robotic surgery live and one 3D laparoscopic surgery live. So 2 cases are shown in that one-day webcast. and it is transmitted through the portal of the Ministry of Health and Family Welfare to 52 colleges across the country and 20 different countries apart from India. And when we started, we got a lot of encouragement from our youngsters and urologists who were watching this. And gradually, we kept on doing this continuously. And as you said, we are very happy to announce now that now we first finished 100, which is again not only the record in the Asia, but also in the world by a single institute, single surgeon. It's a world record. And now, for last 6 months, we have completed 121st. 21, another webcast we have done. Now it is 121 webcast today we have done. And this is a new record. And this just shows that we can use the technology to teach our youngsters. And the main aim of this starting the webcast was the youngsters should not travel from a long distance from across the country or across the other state to Delhi to be trained. They can watch our surgery live. They can ask us questions. They can see how we are managing our complications, and they can learn from that. And this is the best training tool, this best teaching tool in a surgery. And therefore, very few surgeons are doing this across the world because this needs a lot of infrastructure and also expertise. But I would like to thank the Government of India, Ministry of Health, for providing us this infrastructure. And now we are planning to continue this because right now we have 20,000 plus urologists from across the world who have joined us from the last 1.5 years. And with every webcast, it is increasing. And recently, we have also done for the first time the tele-proctoring and the tele-mentoring in the country. And this was also published in the Times of India. And this technique is that I'm sitting here in my hospital and I can teach, somebody is operating, suppose in Gujarat, and I can teach from here that how to do this surgery, and I can instruct him that if he is doing wrong thing, I can instruct him that you can improve or you can correct your procedure. So this is known as tele-mentoring or tele-proctoring, and this is for the first time we have started also. So this is how we continue to evolve with the technology use. And I think my next aim is to start tele-surgery. And I think this is the ultimate because right now tele-surgery is not possible even in any other part of the world. And this is something we are planning to do with the help of our Ministry of Health and Family Welfare.
All right, doctor. Tell us a little about the congenital problems in children and how do you manage kidney problems in children?
The children, they can have congenital kidney problems in the form of, number one, even when they are in the uterus of their mothers, they can have antenatal hydronephrosis. And this is because of the PUJ, pelvic uterine junction obstruction. So there is a routine ultrasound done at in the 7th month of the pregnancy, and there the radiologist can pick up this abnormality that both the kidneys of the fetus is abnormal, it is enlarged. So these are the patients when they are born with enlarged kidney and hydronephrotic kidney. So we have to follow up these patients because we cannot just operate in a neonatal period because less than 1 month is not the right time to operate. So we normally follow up these patients, and by the time of 3 to 6 months, we operate these patients so that this obstruction is relieved. So this is one is the first problem is pelvic uterine junction obstruction. And then some of the patients, especially the male child, they can have PUV, pelvic urethral valve, the posterior urethral valve. So this posterior urethral valve causes obstruction in the urethra part. So when the kid or the child tries to pee, he feels a lot of burning sensation, obstruction, and this problem, when it persists, it can also damage the kidneys. So this is something which is very common, and we treat this by using endoscopic technique, and we fulgurate this valve. Then some children can have reflux. That means they can, when they pass urine, instead of going down, the urine goes up into the kidney and it causes damage to the kidney. So they have recurrent infections in the kidney. They have a lot of pain during maturation. So these patients, especially more common in the female child. And when they come to us, initially we try to keep them on conservative management. But if the VUR, like vesicular reflux, it persists for more than 5 to 6 years and it is causing intractable damage to the kidney, we have to go for surgery, and we do aortic reimplantation surgery. We can do with robotics or lab, whatever technology is there, here we do the robotics, and we can cure the patient. So this is number 3 abnormality. And of course, some patient can have congenital cyst in the kidney, and these patients can have decrease in the kidney function. So again, we have to follow up this patient, and because they can land up in the complete kidney failure.
Right, doctor. I also want to ask you now, what is the status of genetically engineered artificial kidneys in renal transplant?
So, Nidhi, this is a very interesting and demanding kind of involvement which we are all waiting for. And in the United States of America, the experiments are going on. This is known as tissue engineering subspecialty of the urology. And what they're trying to do is they're trying to use the stem cells of the kidney, and they're trying to multiply these stem cells in an artificial medium so that they can form kidney-like structure in artificial medium. And this kidney then can be placed inside the humans, and it can serve like a kidney. So this is the hypothesis. And just like a bone marrow transplantation, in bone marrow transplantation, we inject the stem cells into the patient, and those stem cells actually cure those bone marrow problems. So something like that, that is the hypothesis. But this is still the work in progress. Phase 1 trial have been done. Phase 2 and phase 3 trials, they're still in progress. And we hope that in next 5 years, we will have something which is can be used at least for experimental basis in the humans. But right now, it is work in progress, and we are all looking forward to this.
Absolutely, doctor. Another very important question is that tell us why kidney transplant is so difficult in India even now. You have to take it from your relative or some such thing, and it's not really, it's very expensive. How do we make this more accessible?
Yeah, definitely. The different problems in the kidney transplant is number one, availability of the donors, which is the biggest problem in our country. Every year we need 2 lakh patients who require kidney transplant, but we only get kidneys for 5,000, 10,000. That means every year there is a backlog of 1,90,000. You can think the last 10 years how many lakhs of patients are still waiting for kidney transplant. So the most important problem in India is the lack of donors, because it is very difficult for a living person to be convinced and to donate his or her kidney. And you will be surprised to know that 70 to 80% of donors are females. And as we know, females are always there. Whenever there is a question of charity and the love and emotions are involved, only the female donors are always the first one to come forward and donate the kidney either for their husbands or their brothers or their children. So firstly, we have to sensitize our society so that even the males can come forward and donate the kidney. That is number one. But I think the major issue is the concept of diseased organ donation. As you know, if the patient is brain dead, then he can donate his organ. And one person can save lives of 8 patients by donating the kidneys along with lung, heart, liver, and other organs. So we have to popularize this concept in the whole country. And due to this, the government of India has started the NOTO in Safdarjung Hospital for the last 10 years. So this is something which is work in progress. But this is the second problem, as I said, the less use of diseased organ in the India. Now the next problem is the cost. As you said, if you go to private setup, because the cost is enormous, one transplant can cost 10 to 12 lakhs, and this is only the cost of a surgery. And after surgery, patients take medicines for the whole life that cost to around 5 to 7,000 per month. So a normal person cannot afford a kidney transplant. Now, how to make it affordable? This is what our government of India is trying. So number one, as you know, the government of India started the Ayushman Bharat scheme. And you will be very happy to know now that the government of India has now included the kidney transplant into the Ayushman Bharat. That means straight away they have covered 50 crore people of the country under Ayushman for transplant. So this is number one. Number two, our all tertiary care government hospitals, including the Safdarjung Hospital. I will be very happy to announce that Safdarjung Hospital is doing the kidney transplant successfully since 2013. And we have done hundreds of transplants and all these transplants are free of cost. This is the only hospital in the country which provides all the medications before transplant. During the transplant, the two costly medications are required to avoid rejection that cost around 2 lakhs, 1 lakh per injection, it will be 2 lakhs per patient. That is also given free of cost. And after surgery, the lifelong immunosuppression drugs are provided free of cost by Safdarjung Hospital. And this has been made possible because of the Government of India, Ministry of Health and Family Welfare Corporation. So things like that are being done by the Government of India to make the things accessible and affordable to the poor population of the country. And now, as you know, as the time will progress, more and more people can enroll into Ayushman Bharat and they can avail the benefits of this insurance scheme for the kidney transplant.
Indeed, wonderful news for the, Ayushman Bharat has made such a wonderful announcement, and we look forward to this. Doctor, before I take the next question, may I request you to move the flap of your laptop a little bit, as we can see a rainbow light streaming in. Yeah, much better. Thank you so much. The next question is from Satya, and she wants to know what is the status of gene therapy, what is gene therapy, and tumor vaccine in urology cancer.
So, in simple words, I want to explain why cancer happens. There are two types of genes in our body. One kind of type of gene which promotes cancers, they are known as oncogenes. And the other type of gene is that inhibits cancer, suppresses the cancer, they are known as tumor suppressor genes. So when there is an imbalance between these two genes, that means the tumor suppression genes, they are inhibited, and the tumor promoter genes, that is oncogenes, they are accelerated, then the tumor happens. So what is this gene therapy? If we can either make some kind of vaccine which can inhibit these tumor oncogenes, that is number one, or we can make a tumor vaccine which can stimulate these tumor suppressor genes. These are two concepts. Either of these two, either we increases the action of tumor suppressor genes or we decrease the action of cancer genes. We can control the cancer. This is the whole concept of gene therapy and the tumor vaccine. So for many cancers, the work is in still progress, and we have done a phase 1 trial in the animals. Human trials, they are being carried out. For prostate cancer, we have tried. For kidney cancer, we have tried. Even for bladder cancer, we have tried. But still, this is not still in the market for use in the clinical settings. It is still in the experimental setting. But this concept is, again, as I said, very, very interesting concept. Once we have this in our armamentarium, we can actually prevent also cancers. Right now, we cannot prevent them. We can only early diagnose them, and we can treat in the early stage. By the tumor vaccine, you can actually prevent the cancers also.
Yes, doctor. Unfortunately, we're running out of time, so this would be my last question to you today. We'll request you to join us again, sir. We want to know from you what are the recent advances in the management of kidney failure, and how do we kind of prevent failure? A lot of people have been asking this question to us today.
So this is a very important question. How do we prevent kidney failure? So first, I will take that question first. So my advice to all the viewers who are watching this show, please do not take the over-the-counter drugs. Especially, I'm talking about the painkillers and antibiotics. These are the two group of drugs, and number three, I will add steroids. These three group of drugs, they directly attack the kidneys and they can make them non-functional. So if you take these drugs without any doctor advice over the long period of time, you can damage your kidney. Number one. Number two, if you have diabetes and hypertension, you are at higher risk of developing kidney disease. Therefore, please contact your specialist doctor regularly, be in their follow-up, and control the diabetes and control hypertension. If you keep them under control, your chances of getting the kidney failure will be decreased dramatically, because these are two most common causes of kidney failure, not only in the country, across the world. Number three, we should try to minimize the salt intake. Should take normal salt intake. Do not add the salt to your normal diet, because this again increases the chances of kidney failure. Then increase of the non-veg diet. Now again, you should have the non-veg diet only in the balance. If you take a lot of non-veg, because that puts the kidney under pressure of more and more proteins. Because proteins are being metabolized and they are being excreted through the kidney. So if you take a lot of non-veg food, uh, that can also put a lot of pressure on the kidney. Then of course alcohol and the tobacco. These are two worst enemies of the kidney. If you drink a lot of alcohol and you are a regular smoker, these are the two things which can directly affect your kidney and can damage. So please, if you are using any of these two, try to quit them. And then of course, very important is if you are more than 40 years, for 50 years of age, you should have at least once in a year checkup of your kidney and the whole tract. A very simple test like ultrasound can be done once in a year. One urine test can be done once in a year, and kidney function test, a blood test. So these three tests can be done once in a year after age of 50 years, and more so in those patients who already are diabetic or hypertensive.
Absolutely, doctor.
As you said, yeah. Last you said about the recent advances. So I just want to very briefly comment on that. Now, the kidney failure, we can do the transplant even in those patients who are not blood group compatible. That is, ABO incompatible transplant can be done successfully. This is number one. Number two, we can do transplant using robotics. And this is something which can be used in those patients who are very obese. They have a lot of fat, and these patients they have a lot of complications by open transplant. But with a robotic approach, these complications can be minimized. And number three, we have now newer good immunosuppressant drugs which can prevent the rejection of graft. So we can have survival of graft for up to 25, 30 years. So these are some of the newer advances in the transplant which has happened to further benefit the patients.
Absolutely. And on that very pragmatic note, I'd like to thank you, Dr. Anup Kumar, for joining us and sparing your valuable time in educating us. And with this, friends, this is a wrap of this edition. We'll be back with more interesting questions on Question Hour next week. Until then, stay vaccinated. That's the only way. And stay safe. Keep the mask up. On that note, namaskar. Thank you for watching India Science.